I'm Mayor Howard Rubenstein, City of Saraland. I'm actually wearing two hats today. I've had the honor of serving as a municipal elected official for the last 28 years. In addition, I've had 40 years of serving as a family physician in the community in which I live. So that's a sort of neat combination there. So they asked me if I would moderate this panel today. We had some very valid concerns raised during the previous session, and we're going to try and look at these today and come up with concrete solutions, plans, ideas to improve health care in our state. It's very important to all of us as a physician, a father, a mayor, and just a person. It's very important to me. So we're going to try really hard today to look at all the different factors that are causing problems with health care in Alabama and see what we can do to address them. I've been asked to introduce a very talented panel of experts who will be speaking today. We have, and I'll ask them to come out one by one. We have our Commissioner from the Alabama Department of Mental Health, Kimberly Boswell. We have Ted Hosp, who is Vice President for Governmental Relations with Blue Cross Blue Shield of Alabama.
The starting five in basketball. Starting it going.
Mark Jackson, Executive Director of the Medical Association of the State of Alabama. Danny Howard, Deputy Director, Alabama Hospital Association. And Commissioner Stephanie Azar, our Alabama Medicaid Commissioner. These are five very talented, experienced individuals who are major stakeholders in providing health care in our state. And I'd like each one to sort of introduce themselves a little more. Tell us about what you do and how you fit into health care in Alabama. And we'll start with Commissioner Boswell.
Great. Thank you. Happy to be here today. I was appointed by Governor Ivey as the Commissioner of the Alabama Department of Mental Health in December of 2020, right in the middle of COVID, so that was really fun. I have over 36 years experience in the field. It started at a little hospital in Birmingham called Lloyd Nolan Hospital. Yes. And so I worked pretty much my whole career in the healthcare industry. Also worked a couple of years in Dothan, Alabama, at Charter Woods Hospital in Dothan, and had an opportunity to spend some time with Mayor Saliba on Monday because we opened a new crisis center in Dothan, and we're very excited about that. And really, since 2020, we have been busy building the Alabama Crisis System of Care and building out crisis services in our state for individuals who are in a behavioral health crisis. And so there's a lot of work that's been done in that arena. There's still a ton of work to do, and I'm just really excited to be here. And that was the most fabulous video I've ever seen. It's wonderful. I don't know who did it, but man, what a video. Yeah.
Thank you. You passed the microphone?
Oh, we actually have our own
speaker. That's great.
Hey, good afternoon. My name is Ted Hosp, and I'm with Blue Cross Blue Shield of Alabama. I handle government affairs, so policy and government for Blue Cross. At Blue Cross, we are very proud to provide coverage to approximately 2 million people in the state of Alabama, so overall somewhere in the neighborhood of about 40% of the population. We have the very challenging job of balancing between our healthcare providers and obviously our premium payers and making sure that all of our members have access to quality, affordable health coverage. We, as a company, believe that is something that everybody in the state of Alabama ought to have access to. It is why over the last several years we've been partnering with the Alabama Hospital Association to see what could be done about closing the coverage gap. But generally speaking, again, we're very excited to be a part of the healthcare system and excited to provide coverage to many of you, if not all of you out here in the audience. So appreciate the opportunity to be here.
And we have next Mark Jackson, our Executive Director of the Medical Association.
Thank you, Mayor. Yeah, Mark Jackson with the Medical Association. I have actually been with the Medical Association for almost 40 years. 1986 was my first year. Started out my career doing lobbying, representing the physicians in the state. I was just sitting here thinking about this, and I looked over to my right. I see Greg sitting over there. And I'll admit to this group, I won't tell it to anybody else, but Greg used to work for us. We had hired, what year did you come to work for us? 80? 90. So 1990. We went through a big workers' comp battle back in the early 90s, I remember. So yeah, so Greg had been a part of our organization for a number of years. 10 years ago, I became the executive director, so I'm really not involved in the day-to-day lobbying anymore. But representing physicians across the state, and really excited that other groups besides healthcare groups are starting to pay attention to some of the crisis that we've got going on in the state around access to care. And so it's really exciting to be here with this group, and glad that y'all has got this on your radar, and we can have some conversations about what we need to do moving forward. So thank y'all.
Thank you. And next we have Danny Howard, Deputy Director for the Alabama Hospital Association.
Oh, thank you, and I've been with you several times before in a larger meeting and in some regions of the state. Always my pleasure. I've been with the Alabama Hospital Association for almost 30 years, so we've got some old-timers up here. My hair's not as gray as Mark's, but before I got into the political side of the world, I managed a multi-physician practice in scrubbed in surgery for nearly 10 years. So it brought me a little bit of the clinical side of the world to be able to do what I've been doing with the hospitals. So the Hospital Association membership includes every hospital in the state but two, and that would be Lake Martin Community Hospital and Jack Houston. Over on the Alabama-Georgia line. But we represent every hospital in Montgomery, in Washington, and just on a day-to-day basis, trying to help find resources to include things like labor, workforce. We have a lot of issues, and I'm not going to jump ahead to some of the questions. But the Hospital Association is a trade organization that represents, the one thing that I will say before I stop, and Commissioner Azar, is when I first joined the Hospital Association almost 30 years ago, it was a lot different. And it was a lot different in everything in all of our worlds. These days and now in prospect, I think moving forward, a hospital isn't just about what happens in the four walls of a building. There's an awful lot of outreach and education and partnerships that translate into much more than if you need surgery or if you need to go to the emergency room. And with that comes great responsibility and a lot of opportunity. So we can talk about some of those as we move on.
And we have Commissioner Stephanie Azar for Alabama Medicaid.
Thank you. As he said, I'm Stephanie Azar, and I came to Montgomery from North Alabama many years ago, and I actually have over 25 years of experience working at Medicaid. I came into Medicaid, and I'm an attorney by trade, and I came into the Office of General Counsel there, worked my way up to be General Counsel in 2010, and was appointed Medicaid Commissioner in 2012 of May, so I'm coming up on 13 years in this role. I also am very active in the National Association of Medicaid Directors, which is just invaluable. I have contact with the Medicaid directors across the nation, so it keeps Alabama Medicaid able to be in the know what's going on across the nation, what things are working in some states and things that aren't working in others. Medicaid really is focusing on, as you know, we cover the most vulnerable populations. in the state, being our elderly, our disabled, our blind, our pregnant women, and most of our aged, and then most of our population are actually children. A lot of people don't know that. We also cover over 50% of the births in Alabama. So I think everyone in this room I know is an advocate for that how valuable Medicaid is to the state of Alabama and how important it is. And our programs at Medicaid, we're trying to move away from just being a payer of claims as an insurance company. We're looking toward incentivizing quality so that we can have our members be able to be as healthy as possible, have access to the providers that they need to be, and managing that across the board. So I'm very glad to be here with this esteemed panel today. I work with everyone on this panel pretty regularly. So I thank you for letting me be invited today.
Thank you. I'm going to try and outline some of the problems, the challenges, the opportunities to improve healthcare in Alabama. As was very well articulated by several of our elected officials when the Lieutenant Governor was speaking, there are multiple issues right now with healthcare in Alabama. The biggest issue from my standpoint is access to care. That's very important. It's very important to the league. It's very important to all of our elected officials here, is access to care. This is a very complex situation, and Medicare expansion is just one part of it. There's multiple other facets to it. But the whole access to care needs to be looked at and, in my opinion, revamped. And you got to be a little bit careful when you do this. I just want to give an example. I had the opportunity to go to Canada last year, and my first trip to Canada, and I got to speak to a lot of the Canadians, and they're well known for their different type of healthcare system to the way it's done in the United States. So I got to talk to a lot of just regular people and asked them, what's your healthcare like here? I hear it's wonderful. And they said, well, not so much. So I said, why is that? I said, well, what happens if you get sick? Do you just go see your doctor? And they said, no, it doesn't work like that. And this is for everybody, not just low-income citizens. This is for everybody. If you get sick, you wake up and you're sick one day, you go to your neighborhood health center. You have to be there by 8 o'clock. You take a number. They give out numbers when you walk in, and the numbers are called one at a time until they get to you. The numbers are all gone by 8:30. So if you don't get there by 8:30, you're not going to get a number for that day, and you have to come back the next day. If you do get a number, you have to sit as long as it takes to get your number called so you can get your flu or your strain or your diarrhea taken care of. So that's something that we don't usually have to do in the United States, and makes you think a little bit. Another thing that multiple Canadians told me is that their primary care doctors are pretty good. They're caring. They try and do a good job. But if you need a CAT scan, if you need an MRI, if you need to see a specialist, no problem. You get on the list, and 6 months to a year, you get to have your test done or see your specialist. So again, something we take for granted here in the United States is totally different in that country just north of us. So as we look at changing our healthcare system, I think we need to keep in mind that we don't want to make things worse than they are now. We want to make things better. And there's lots of opportunity out there, in my opinion, to make things better. The second major issue that I believe we have in Alabama right now is a problem with physician and provider care distribution. A lot of people like to say we have a physician shortage in Alabama. We do not have a physician shortage in the state of Alabama. It's simply a matter of distribution. We have some areas where there are almost too many physicians, and we have other deserts in Alabama where entire counties don't have a single provider who can deliver a baby, which in 2025 is, to me, utterly ridiculous. So we need to come up with some way to encourage healthcare providers, physicians, nurse practitioners, physician assistants, to want to practice and live in some of these areas that really need help. This is going to be a complex problem. It's getting more and more difficult every year, and it's going to, in my opinion, it's going to take more than just saying, we'll give you a $5,000 tax rebate at the end of the year. For a physician, offering them $5,000 to practice in a community where they have very little backup, they're going to be worked to death, all the challenges that come with rural medicine, it's going to take something more to make an incentive for people to want to set up shop and work in these areas. But it's so important that we correct this problem of distribution. The third major issue is our healthcare facilities in the state. I almost cry. It seems every time I read, I hear about another rural healthcare hospital closing. We've had multiple hospitals close in the state of Alabama. And now recently, right here in Montgomery, it's my understanding, there's questions about maintaining services at one of the largest hospitals in our state. And that's just plain scary to me. So we also need to be working together to make sure that we have quality, well-staffed healthcare facilities throughout our state where our residents can get to them and be treated in a timely and a quality and a comprehensive manner. And now that's a whole lot of problems, but I do think that we've got some great brain power up here, some ideas, and my first question to our panel, and I'd like each one to comment on it, is what do you see as solution or solutions to some of these problems that we've got in Alabama right now? And I'm going to start with Commissioner Boswell.
Okay. Where is my magic wand? Did I leave that at home? Much of what we've done over the last couple of years, particularly to improve behavioral health services in the state, is building out the Alabama Crisis System of Care. And what that really means is if you're having a mental health crisis, a crisis center is a place you can go 24/7. So often when individuals are in a mental health crisis, the first thing they do is dial 911. If you dial 911, you've got two choices. You're either going to get law enforcement or EMS. If you get law enforcement or EMS, they have two places to take you, the ER or the jail. So the beauty of the Alabama Crisis System of Care is, first of all, there's a new 3-digit number to call if you're in a behavioral health crisis, 988. How many of you have heard of 988? Yay. So the first thing we wanted to do is have an easy-to-remember 3-digit number to call instead of calling 911. And so once you call that number, you can be directed to a crisis center. We now have 6 in our state. The 6th one opened on Monday, where you can receive an assessment, where you can stay in a 23-hour temporary observation setting, or you can stay 5 to 7 days in a crisis stabilization unit. And so as we all know, a crisis doesn't happen neatly between the hours of 8 and 5. And before we stood up our crisis centers, if you needed help and you called your local community mental health center, one, you were probably going to have to wait. And that doesn't work well. That's what leads to the phone call to 911. And so really improving that access to care and helping people have an easy way to get into the system, even if you don't need to go to a crisis center, but you're just not sure who to call or where to go, you can dial that 988 number and get access to care in any part of our system.
Thank you very much. Speaking of mental health, they really do a great job, and it's really a high-need area in our state. A few years ago, down in our south part of the state, we lost Searcy Hospital, and that's been a really hard vacuum that has led to a lot of people ending up in other places who badly needed treatment. So I'm very pleased that they've created this crisis care method where you can get the emergency care you need in a crisis. Another thing, I'm just going to throw this out today from my experience. Florida has something called the Baker Act, and I'll get to that in just a second. In the state of Florida, if a physician has a reasonable belief that a patient or somebody he's treating is a danger to themselves or others, the physician has a right to have this person involuntarily admitted, thank you, and evaluated over a 24-hour period so a professional can determine are they really an acute danger to themselves and others. There is currently not anything like this in Alabama. And one scary situation, and I experienced this during my career as a family physician, is a patient walks in to see you and says, "Hey, Dr. Rubenstein. Hey, Mr. Jones, how you doing?" "Well, actually, I'm doing pretty bad. I've had X, Y, and Z bad things happen to me today, and my wife's leaving me, and I've lost my job, and I've got a gun out of my car. It's all loaded, and I'm about to go out and take my life. I just wanted to come by, though, and thank you. You've been a wonderful family physician to me over the last 20 years, and I just don't want you to blame yourself for what I'm about to do." So what can Dr. Rubenstein legally do in the state of Alabama? Not much. So I would, and I brought this up, I serve on the Human Development Committee with the League. I would really like our legislators to look at putting something where if a healthcare professional feels somebody is an acute danger to themselves or others, we would have some authority to get them the care they need, whether they think they need it or not. So I just want to put that thought in your brain and let you marinate on that a little bit. Ted, what would you like to talk about?
So, yeah, you mentioned the trouble of where physicians and medical professionals are located. And starting in 2016, Blue Cross Blue Shield of Alabama dedicated $11 million to Rural Physician Scholarship Program. And so far, we've had about 149 students who have entered into this program. 30 or so have graduated from the program and are now starting practice. And the way that the program works is Blue Cross will pay for the last 2 years of a student's medical school, and in return, the student commits to spend at least 3 years practicing in a rural community. You're exactly right. If you're talking about a $5,000 tax credit at the end of the year, given the amount of debt that most medical students come out of med school with, it's not really going to be enough. This is a soup to nuts program. We help them find office space. We help them find their office equipment to make sure that they have a place to practice. We set them up kind of at the beginning part of their practice, and we're very excited again to have 29 practicing physicians. Just last year, we renewed the program, so it was $11 million starting in 2016. Just last year, we committed an additional $13 million to the program, so $24 million total. And we've expanded it. We recognize there's also a nursing shortage in rural communities, so we are now providing nursing scholarships as part of this program. We have a maternal care crisis in the state of Alabama, so we are specifically setting aside a portion of those funds for doctors who go on and get the additional certification to be OBGYNs and then go into a rural community and practice. Mental health professionals is another focus that we added to this scholarship program because we know, again, in rural communities especially, there is an extreme shortage of mental health professionals. And we're talking about, really, for the most part, primary care here, right? Not crisis care necessarily, although they obviously will provide that. But what rural communities lack in many respects, there are hospitals, though they are struggling. And Dane will speak much more detail to that, I'm certain. But it is very hard to attract those primary care physicians, pediatricians, internists, OBGYNs, psychiatrists, nurses. That's the goal of this scholarship program. So again, $24 million has been committed. We're having people come through the program every day and set up their practice. We have partnerships with all 4 medical schools in the state, ACOM, VCOM, UAB, and USA. So we're hoping at least that will help with the distribution issue regarding both physicians, psychiatrists, and nurses.
Ted, if I could follow up with that. I know it's probably too soon, and this is a great program. It's probably too soon to do before. Well, other states, I think, have done similar programs. What's the retention rate? How many of these physicians stay in their communities when their 3-year obligation is over?
So it's hard to know yet because it is such a long process as they go through med school. We're picking them up in the 2nd year, but we haven't had anyone leave yet. And over the course of the program, we've actually only had 3 students that I'm aware of who I'll say dropped out. In other words, we had one who decided med school just wasn't for them. We had one who decided to practice out of state. And if they do that, they are required to pay the scholarship funds back. And then we had one who decided to stay in Alabama but not practice in a rural community. Again, that person was required to pay the scholarship funds back. We base the 3-year requirement to be in a rural community because all of the studies that we had said once you stay in a community for 3 years, you really establish yourself and you're much more likely to stay. So to my knowledge, once the folks have joined those communities, I'm not aware of anybody who's left. And like I said, we've only had 3 students, to my knowledge, who have accepted the scholarship funds and then not continued through to locate in a rural community.
Thank you.
I'll follow up on that question to what Ted just said. So statistically, we know that if somebody stays 5 years, so 3 years would be a variant to that, but if somebody stays 5 years in an area, you've got about a 95% retention rate. So kudos to Blue Cross and what they're doing with their program. There are some other programs that I was going to mention in a minute. I'll come back to that. But there are some other programs where there is some funding available. Particularly for you, the mayors out there, I want to make you aware of one program that provides physicians who will locate in an underserved area $50,000 a year. So that's some substantial money. It's not going to solve everything, and it's not it's not a silver bullet out there, but it is some. There are some monies out there from some different programs that are available that I want y'all to be aware of. But let me take a step back to the original question, and monies. What I just said, monies, I think is the crux of everything. We've got to. We got to get funding. We've got to get funding on the state level for different programs, and let's start with the elephant in the room. Let's start with Medicaid expansion. And these two to my right and left have been actively involved in that, promoting that for years now. Are we making traction? I'll let them answer that question. But look, I mean, Medicaid expansion is not going to solve everything, but that's where we need to start. I was told that Lieutenant Governor was here earlier and made his speech, and some of you in the audience questioned him about, didn't hear any talk about health care. Well, he probably was surprised to hear that from this group. If he was speaking to my group, yeah, he would expect a question like that. So I was glad to hear that y'all are engaged in asking those questions, because legislative leaders need to hear that from other folks, not just from hospitals or from the physicians or Blue Cross. They need to hear it from groups like y'all. So kudos to y'all for saying that. And keep that pressure up. Maybe we will get to the where we need to be. But yeah, how do you tackle this? I think it starts with funding. It starts with getting our state leaders to step up to the plate and put money into these, into these various programs that are out there that will make a difference. And with some other questions, I'll come back and talk a little bit more about those programs.
Thank you. Dane?
Okay, I'm going to hit just a couple of things they talked about already, but I'm going to start off by saying this. The crisis, and we have a healthcare crisis in our state right now. We have a crisis. It's not just one thing that caused it. It's years of many things, and a lot of them have stayed the same throughout the years. And we have continued to say throughout time, if all things stay the same, it's only going to continue to get worse. And that is exactly what is happening. I couldn't agree with the mayor anymore about the mental health issue, and very familiar with the Baker Act in Florida. One of the things Florida did do before they passed the Baker Act was they built up their resources for mental health first. And then they had opportunities for those who were having mental health crisis to have a place, to have the resources to treat them. Right now, I don't want to be the yeah, but the reality is right now with the Baker Act, similar to a Baker Act, if you take a patient to a hospital emergency room to be evaluated to determine if they need more intensive care, first of all, not every hospital has mental health resources. Secondly, assuming that there was an evaluation that determined, and it wouldn't have to be a mental health specialist, doctor, you were able to tell this person that you just referenced needed help. The problem then becomes with Commissioner Boswell and I having to talk, there's not a place for that patient to go to get the inpatient care because there's not a bed available in any of the mental health facilities to be able to extend that care. And the ultimate tragedy in all of this is many of those patients are held in hospital emergency rooms, and we're doing our best to take care of them and get them the help that they need, sometimes for more than a year, waiting for a bed that it could actually help them. So to Mark's point, we need funding. We need mental health funding to help have more inpatient facilities, to have more access to care. The outpatient crisis centers are great, but if they need inpatient care, that's where the roadblock comes. The physicians, these are two great programs that we support mightily. Hospitals operate not without medical professionals. It's very difficult to recruit physicians or any medical professionals to a rural area when you can't make a living. It's very difficult when the majority of the patients that you are going to serve don't have health care insurance, and the only place they have to go is a hospital emergency room for primary care. That creates just a vicious cycle and a death spiral for the providers in that area, which ultimately leads to the loss of access, which is where we're seeing things now, and it's not getting better. It's not going to get better until we figure out what things we can do, one step at a time. Realize there's not one thing that's going to save the system at this point. Some of it is suffering that can't be pulled back. But there are a lot of things that we can do that will have a long-term impact to shore up our healthcare delivery system for everyone. I am very proud of the work that the Alabama Hospital Association has done in partnership with Blue Cross in going across the state and having many conversations about closing the coverage gap. And the closing the coverage gap between our organizations and working with the Medicaid Commissioner and others. We got data from her. I want to be clear. We have designed a plan or came up with a plan to suggest to help close the coverage gap that would be specific to Alabama. No other state in the country has it. And we won't go into all the details. You heard an awful lot about that in previous panel discussions, I think last year even. Clearly, just to go ahead and answer one question before it gets asked, there's an awful lot of talk going on in Washington right now and a lot of uncertainty about what Medicaid and Medicare and other programs are going to look like. And so knowing that uncertainty is happening and it's real, I don't have any projections or crystal ball about what may or may not happen, but the conversations are difficult and hard to hear, and depending on what direction they go, could have devastating impacts on our state and our state budgets as it relates to health care. So I think we're pausing the push on closing the coverage gap, but don't pause the talk. And I'll reiterate what Mark said. The talking that you're doing, the communications you're having, and getting more information to understand, help your communities understand. There is more misunderstanding about the healthcare delivery system than I ever realized. Hospitals, physician offices, you're going to be there, or so people think. More conversations that you have is exactly what we need to be doing, and so we'd love to be a resource anytime that you need us.
Thank you. Commissioner?
Yes. would say we're a little bit different being with Medicaid in that we don't provide services, and even some other state agencies like mental health and other groups do. So we are basically a payer of claims, and as I stated a moment ago, trying to move away and trying to incentivize quality through our stakeholders. But with the healthcare crisis and being a governmental funded program where we don't charge premiums, we can't do that. I'm not advocating for that. But we are heavily dependent on our provider taxes and assessments and our general fund, obviously being a large one. The healthcare crisis due to inflation is one of the things that I am seeing now. Many of you may know Alabama Medicaid is coming in with one of its largest budget requests it's ever had because we've lost a lot of the carry forward from the COVID pandemic that we have brought in. So we're coming in requesting over $1 billion from the general fund alone, which should bring in over $7 billion in federal dollars once, if we're appropriated that, which is just vital to it. So from my standpoint, on a daily basis, we are having to attempt this absolute best that we can to balance that exceptionally high inflationary rate and costs that are coming in, at the same time being able to pay proper rates to our provider base, because they are the ones that are administering that care and they are vital to that. And we have implemented programs, which I'll get into a little bit more later, that incentivizes quality through some of our Alabama Coordinated Health Networks and other things that we have implemented, which the primary goal of that is really to help that recipient be able to be care managed, to get to the care that they need, locate the providers that they need, be reminded to take their medicine or whatever slew of those things are. And the ultimate goal is to hope that that Medicaid recipient has a better quality of life and becomes healthier, maybe needs to go to the providers a little bit less. And the goal of our program would be to build that efficiency into really what's happening is that healthcare inflation is making that cost curve is going up. So our goal and some quality initiatives and other things that we're undertaking is to try to maybe slow that just a little bit so it's not going as rapidly as it is. And it is not an Alabama Medicaid program. It is, as I stated earlier, being on the National Medicaid Directors, it is a national problem as far as the cost of health care. So we're doing the best we can with very, very limited resources. The legislature time and time again has come through and has appropriated us, and I'm forever grateful for that, and allowing us to be able to do what we need to do to serve the most vulnerable population that we have on the program.
Thank you, Commissioner. And I want to say, Medicaid in Alabama does a very good job of providing this health care to those patients who really need it. So thank you for what you do.
Oh, thank you.
Getting a little bit more into specifically access to care. And again, I want to picture this, it's not just Medicaid expansion. That's important, but it's global access to care where every Alabamian has a way to get their health care and be able to have it paid for, pay for it themselves. Commissioner, what do you think is your ideas to help that access problem?
Well, at Medicaid, that's one of the things I was hoping you'd ask, so I can talk a little bit about what we have going on to help with access in our program. We have created a couple of programs have stood up, and our Alabama Coordinated Health Networks being one of those that ironically only launched about 4 months before COVID hit, so that was a very enlightening experience. But that program, we have 7 entities that are in 7 divided out regions in the state in Alabama who are processing and working through care management for our population across the community and across with our providers. And in that program, in relation to the access, is we do have, for lack of a better word, incentives or bonuses for that provider base for moving some benchmarks like substance abuse, obesity, maternal health obviously is a huge one, infant mortality, things such as that. So that when we have received really good participation from our provider base on that. So that is really helping us have those agreements with those providers so that those recipients have those providers there to be reminded to go to and where they need to get the care across the line, which is very, very good. Also, we have our integrated care network, which is kind of similar, but it deals with our elderly population. And really what that is doing is we have a statewide contractor that helps with that, is trying to make sure that our elderly and disabled population is in the right place at the right time for the right care. And therefore, if they can be served properly in the community, then they can stay in the community longer. If they need that nursing home care for various reasons, then they're there as well. So we have those in place. I'm also very pleased to mention that we were able to be funded over the last year and a half for the Nurse Family Partnership Program. That is to help coordinate maternal health and also really helps with child development up for a year after birth has occurred. And we now have 1,000 families enrolled in 28 counties with that. We're helping get them access to what they need to the provider base as well. So we're very, very pleased with that. And also another thing that's very important, I don't think anybody would ever want to think that there could ever be a silver lining to COVID. But I would sit here and say that the Alabama Medicaid program did have some telehealth that was occurring before that, but that forcing us, so to speak, to have to really get out of our wheelhouse and get into that has just been a game changer. Alabama being as rural as it is, and particularly Commissioner Boswell, it's been highly utilized for like mental health therapy, which, you know, if you have a mental health crisis, you have a physical health crisis. A lot of people don't know that, but we do know that. So that telehealth is being utilized greatly, and I think that's just a wonderful thing that is also helping have our Medicaid recipients and members be able to have access, maybe even from their own home, to be able to talk to their therapist, or they can't make it to their provider and that sort of thing. And the provider base has been phenomenal in helping adapt to that and be at the table with all of that.
Thank you.
You're welcome.
And I want to salute what Medicaid's doing for preventive care. A lot of people don't realize the importance of preventive care. You know, what's preventive care? Why is it important? We have found, and this is scientifically proven, that if you can provide this care on the front end, it reduces astronomically the costs on the back end. If you can take a diabetic, diagnose them early, get them on the appropriate diet, the appropriate medication, 20 years from now, you're not having to pay to amputate a leg off. You're not having to pay for an expensive eye surgery because they can't see. You're not having to pay for heart disease that's been caused by their problem. And so much of our state in the United States, and Alabama is not high ranking on this, is because of poor health habits and lack of preventive care. It really bounces to that other end of the spectrum where they end up 20 years, 30 years later in the hospital requiring thousands and thousands of dollars of very, very expensive care to do at that time the best you can do for the state they're in. So I just can't emphasize that part of whatever solution we can all come up with, preventive care needs to be a big part of it. Another part I think is important is motivating patients, and that's something healthcare hasn't always been really good at. You know, if a patient walks in and I say, you know, you're looking fat these days, Mr. Jones, that doesn't do a good job of motivating that patient to do something about their health. So we both need better training, we need incentives, we need to carrotize, throw a carrot at people to make them realize it's so important on the front end to get this preventive health instituted and stick with it so we can avoid all the terrible things right now we're seeing at the back end that's making up this humongous share of our healthcare burden right now, if that makes sense to everybody. Dane?
Yeah, everything, yes, that you said too. You know, I'll go back to just echoing some of the other things in here too. And one of the things, again, the Commissioner Medicaid Agency in Alabama does a phenomenal job. I do want to make sure, and I know that you do, so I'm just going to say it again, though, that you understand who is eligible for coverage at Medicaid. If you are an adult between 19 and 64 without children and you're not disabled, you don't qualify for Medicaid. Unless you get pregnant. And then once you get pregnant, yes. You know, one of the goals in closing the coverage gap, if you look at the infant mortality rates in Alabama, we are some of the worst in the nation. Maternal mortality rates as well. Now, yes, if you're pregnant, you qualify for Medicaid, so you have health care coverage. But one of the goals that we would like to see in closing the coverage gap is to provide health insurance to these women before they get pregnant so that they're healthier and then they have a higher chance for a healthy delivery and a healthy baby. So waiting until they're pregnant to get them health care when they may not have had as much resources before is part of the problem. And so that is one of the things that we're also trying to, why we're promoting closing the coverage gap, why we are working so hard through other programs in the meantime to see what we can do to have better access that allows for every bit of the preventative services that you just said. Cervical cancer should not be a leading cause of death in Alabama, and it is. There are tests that could catch that earlier. So those are the kind of things, and hundreds of millions of dollars would help.
Mark? So while I'm thinking about it, one of the things I had on my list to give a shout out to was to Medicaid and to our partners at Blue Cross, because the Commissioner mentioned telehealth. So when COVID hit, the provider groups made a big push to try to get the payors, Blue Cross and Medicaid, to pay for telehealth, because obviously you weren't COVID, you weren't able to get in to see them and see your providers in person. And I think there was some hesitancy, they'll admit to you, there was some hesitancy for them to start paying for these telehealth visits because they didn't know what it was going to cost, and we didn't really either. But we were encouraging them to, particularly when in rural areas where there's not access to internet, to pay for a telephone call. And again, there was some hesitancy there, but as Commissioner said, they did, to their credit, and kudos to them, start paying for that and have continued to pay for that. And we're much appreciative of that, because I do believe it's a game changer that is still evolving, and I think it will still provide even more benefits in remote areas, not just remote areas, but everywhere. But it's a new way of thinking of the delivery of health care. But it needs to be paid for, and again, I appreciate our partners there for paying for that. I mentioned earlier two programs that I wanted to mention to y'all. One in particular that I think you can make a difference with, and this is called the Alabama Rural Medical Services Awards, or basically grants that are out there. The legislature has appropriated about $2 million. And that is for physicians or nurse practitioners who locate a practice in an underserved area. So if you're trying to recruit a physician to come into your city, you need to know that this money is out there and this money is available. They will award up to $50,000 a year for 3 years. So again, that's decent money for a physician or a nurse practitioner to locate in a city that qualifies under the criteria. So far, we've got about 20 physicians located in 15 cities, and I brought the list of cities. Let me find it. I'll tell you where they are now. And, the program is a couple years old, so I think people are just learning about this, and I can provide Greg more information if y'all want to find out about it, of where you can, as you're recruiting physicians and trying to entice them, the recruitment that you were talking about. That's just one part of the piece that you can, of some resources that are available to you. But just so you'll know, cities right now that are taking advantage of: Athens, Demopolis, Fort Payne, Boaz, Millry, Vernon, Foley, Jasper, Enterprise, Summerdale, Alex City, Alberta, Ozark, Atmore, and Ranburne are the cities where there are physicians now practicing who have taken advantage of the money that's available to them. The other program is maybe you don't have as much influence over, but just to let you know that it's out there. It's called the Board of Medical Scholarship Awards. So these are for students, residents who are getting ready to enter into practice. There is money available to them that if they will locate in a rural area, they can have their tuition debt paid for. And obviously it requires service in an area, and it goes back to what we commented earlier about 5 years of service. If you'll stay 5 years in a rural area, you can have that medical school debt 100% paid for. And we believe that the statistics show that if they spend those 5 years there, 5 years, not 3, if they spend those 5 years there, they'll stay. And so we do believe this is a an opportunity. Now, as we've all said up here, there's no silver bullet. It's not any one thing, but it's going to be a combination of a number of things that's going to make a difference. But those are two programs that the legislature has funded. We need to get them to continue to fund it. We need to get them to increase funding for those programs. Obviously, the more money that's available, the more grants, the more scholarships that'll be available to get people into your communities. So those three things is the three things I wanted to mention that we've got going right now.
Thank you. Ted, before I let you speak, I want to give Blue Cross a shout out. Blue Cross is more than an insurance company in Alabama. They've been extremely proactive with multiple programs to improve health care in Alabama, including access. When you look at the All Kids program and the things they do with physicians, where they incentivize physicians to think about preventive health, even tie it to reimbursement sometimes, where the more preventive health you do, the more you get paid. They've been really at the forefront of encouraging some of the change that we're going to need if we're going to attack this crisis. So I just want to thank Blue Cross for everything they do for us.
Thank you. That's very kind, and I need you to come up to the legislature with me after this, if you don't mind, and say the same exact thing. But prevention is an important part of what we do. It's a little different for Blue Cross than it was many years ago when we got the claim, we paid the claim. There's a focus now on how can we provide a more holistic approach to our customers, and not just our customers. We're extremely proud of our partnership with the state. The commissioner, Medicaid commissioner, mentioned the Alabama Coordinated Health Network. We are pleased through our subsidiary MyCare Alabama to coordinate the care for those recipients in 3 of the 7 regions of the state. We also, through the Department of Public Health, administer the All Babies. You mentioned All Kids. We also have the All Babies program, which is a free program through the Alabama Department of Public Health. It is modeled after a program we have available to all of our members, which is the Baby Yourself program. But the All Babies program provides counseling, including mental health counseling, but also prenatal counseling, substance use disorder treatment to expecting mothers. It is designed, again, to hit that preventative piece that is so important to make sure that we have healthy babies who are being born. And we do incentivize both our patients, our customers, to make sure that they are getting their wellness visits. If you are a Blue Cross customer, you probably are aware you've got to designate a primary care physician before you can go and see other doctors. And the purpose of that is to make sure that we can track and make sure that you're getting your annual wellness visits, that you're testing, that you're getting your blood tests. Where are you on your glucose levels? Where are you on your cholesterol levels? The goal, obviously, is to make sure that everybody is healthier, happier, but it's also there is a cost angle to that, because every person who ends up in the emergency department is going to be a higher cost claimant than somebody who maybe you can prevent from being there. So we have focused very much on prevention, and again, very pleased to be partnering with the state on a number of different programs to be helping folks who are not just Blue Cross Blue Shield premium payers.
Thank you. Commissioner?
There are a couple of things in Alabama, as I said during my budget presentation this year, that we need to do to improve access to care in the state of Alabama for behavioral health care. We need crisis services in all 67 counties, and we need civil commitment beds. We now know that you need, at a minimum, 30 beds per 100,000 individuals. Alabama right now is at 13.4 beds per 100,000. So if you are willing to go to treatment, you can access care through crisis services. But if you're not willing and you have to go through a probate commitment, which is the kind of services we provided at Searcy Hospital, We're sitting at 13.4 beds, and the minimum that we should have is 30 beds per 100,000. And so a big part of our resource request this year is around increasing the number of civil commitment beds in the state because we are at a very low rate. And so doing those two things, we've presented sort of a 5-year financial plan that would allow us to get crisis services in all 67 counties and at least get us to 30 beds per 100,000 individuals in our state. Also want to talk a little bit about a wonderful program called PATHS. It's a public-private partnership with Children's Hospital in Birmingham, pediatric access to telemental health care. We have 120 physicians, primary care physicians, mostly pediatricians, around the state who actually are connected to the professionals at Children's Hospital and can provide mental health services in their office through a telehealth medium. And so when COVID hit and our kids were really struggling, the thing that actually saved us was that program in partnership with Children's Hospital. That program continues to expand. What we know as mental health professionals is families, parents are much more likely to discuss the mental health of their child with their pediatrician than they are anyone else, whether it's teachers, whether it's mental health professionals. And so one of the things that we've really looked at is who is that trusted advisor that someone is going to say, I have a mental health issue. Often it's a pediatrician. We also have some faith-based programs because we know many times in lots of communities, the person you're going to go talk to is your minister. So we have some faith-based support specialists. And really a lot of what we've been trying to look at is how do we get past the stigma of mental health? Who is an individual talking to? Is it their minister? Is it their physician? There's another integrated care model that we worked with, actually Blue Cross and Community Foundation in Birmingham, to get approval to put a professional in an OBGYN office. And so really for us, we are always looking at who are people talking to and how do we make sure those individuals have the most information so that they can get folks to the right place. But I joked this year that I should have named my presentation, budget presentation, beds, because really at the end of the day, we need more beds. The reality is we don't need to run big facilities like Searcy Hospital. Searcy Hospital could only be paid for through state dollars. So big hospitals like that are absolutely not the way to go. We have 16-bed crisis residential units in communities. Part of the reason is if it's 16 beds or less, we can combine state and Medicaid dollars to pay for those services. And so a lot of what we're looking at now is regional facilities in local communities. We actually also buy beds from community hospitals. So many of your community hospitals are now designated mental health facilities, and we buy beds in community hospitals to take care of our civilly committed individuals, but we don't have enough beds.
Thank you.
Sure.
There's one real important question I want to make sure I ask today. We're very fortunate. We've got some of the most talented, most dedicated municipal elected officials in this room right now. And I think earlier during lunch, we heard some of the passion, some of the worry, some of the concern for our residents that we all have in these various areas of healthcare. I'd like to ask each panelist specifically, what can we do as municipal elected officials to effect positive change in healthcare in Alabama? Commissioner.
So our system is operated through 19 community mental health centers. What I would say to you today, the most important thing you can do is have a very strong relationship with your community mental health center. You actually, as municipalities, have the opportunity to recommend individuals for your community mental health center boards. And so you need to be making sure that you are in communication with your community mental health center, that you have people on the board who understand the mental health issues in your community, because your voice is really, really important. You know, you have police officers and first responders and others in your community that are dealing with the mental health crisis in your community every day. And so what I would encourage you to do is to get involved with your community mental health center in your area. And I will be happy to send the names of the executive directors and the phone numbers out. I'll make sure I get that to Kayla and others.
Thank you. Ted?
Well, I mean, again, I don't have any magic advice here, but I will say, I think the more you can engage on a very regular basis, not just during this 105-day period of the year when the legislature is in session, but engage and have that special relationship with your Alabama legislators, both your senators and your House members, and stay up to date and in their ear about the healthcare issues that are affecting your community. Mark's mentioned a number of different programs that have some funding but are going to need to be reauthorized at various times or more appropriations. Commissioner has mentioned the same thing on budget requests. Both commissioners have. And so the more you can stay engaged with your state legislators, I think the more influence that you can have. And again, like every relationship, it's not calling when, you all know this, I'm not telling you anything. You know, it's not, that has to be a day-to-day relationship that is grown and nurtured over that time so that it's an easy phone call to make when something comes up.
Thank you. Also, I'm sorry, Mark, before we go further, I want to remind everybody that later today, you will have the opportunity during a reception to interface with a lot of our state legislators. So please don't be bashful. Share with them everything you're learning today. You'll have they'll be munching away on all this good food the league's serving them. Take advantage of this to get in their ear and have these conversations with them.
Yeah, so ditto. My own? Yeah. I was going to say the exact same thing. I mean, what you're doing here today, be involved. And most of y'all are all elected officials, so you know how the game works. You've got to have those relationships. You got to stay in their ear, like Ted said. You know, Greg and his legislative team can do all that they do up at the legislature, but without the folks back home getting in their ear, talking to the legislators, telling them how important health care is. And look, I know y'all got a lot of other issues that you're facing at the city level, but when you start talking to them about health care, like I said earlier, I guarantee you Lieutenant Ainsworth didn't expect to get that question from this audience. So when you and other groups like you start having conversations with them around health care, it's going to start moving the needle. And so just ditto to everything that's been said so far. Get involved, stay involved, and let's make a difference.
Yes, same thing. You already are. I guess the learn more, talk more. I know probably in most of your communities, the hospital is the largest employer. What does that mean to the economy in your cities? In most counties in the state, the hospital and healthcare is the largest employer. Economic development, it's not healthcare, but economic development is dependent upon having a healthy healthcare system. Jobs are created because of this, inside and outside of the hospital walls. So I think learn more, get more informed, and talk more. It's not a partisan issue. This is not about Republicans or Democrats. This is about the communities that you serve, that we serve, and making our state more attractive for more economic growth means having a robust healthcare system that's able to have a healthy workforce to get to work.
So since you said economic development, before I steal your thunder, that was an excellent point. We're all about economic development. Everybody is. We're all about it, but oftentimes healthcare gets left out of that equation. And so to Dane's point, we got to talk about healthcare and what it does in terms of economics within your communities, both the hospitals, both the providers. It's a huge, not only for the health needs of your communities, but what it does economically to your communities. And when you lose a hospital, when you lose a provider, it's devastating. So we need to do a better job, need to, and y'all as well, of correlating the economic development as it pertains to health care.
But they're tired of hearing from us, which is why you got to talk more.
Commissioner?
Yeah, I just echo everything they're saying, is to learn and be as educated as you can about healthcare, and particularly with Medicaid. I know we do Medicaid 101. I did a little bit of that today as to how many people we cover. And every single county and local community has a significant amount of Medicaid members in it. And a lot of people just don't recognize that. So it's very important for that. And we are here, I've gone out and spoken to some municipalities. I think knowledge is power. Obviously, since you have so many vulnerable recipients in your area, that I would always say that just to let your legislature and others know how vital it is to your local community, because we are very vital to your local community, and to voice support for the funding of the program is always good, because it is just so vital to even the economy. I mean, we're bringing in over $7 billion a year in federal dollars that goes out to pay for help the claims for providers all the way across the board. So I would just say stay in the know and be active for what you want to see happen.
Thank you. Dane, I got a specific question for you. We've touched a little bit about this, is the crisis with our healthcare facilities right now. Hospitals closing. Besides, it's sort of obvious that if you increase funding, more access, that would help the problem. But what other things can be done to help preserve quality healthcare facilities in Alabama?
Well, good question. And support what we're doing here today and talking about things. I mean, we are internally with hospitals looking at the entire delivery system. What changes can we make? What things need to change in the delivery system so that access is preserved? There's a new designation called a rural emergency hospital that was created by Congress as a last-ditch effort to prevent a hospital from closing. Help with education in the community, help with some of the deserts that we have now. We can't fix that without better reimbursement. At the federal level, Medicare, Alabama is the lowest reimbursed in the nation from Medicare, by far, the lowest reimbursed in the nation. Every payer source to provider to hospitals is the lowest in the nation right now. Our costs have gone up. Labor costs go up. We do a lot to incentivize and retain our employees and trying to get more. My eggs at my house, since eggs are the topic all over the place now on the news, eggs at my house have gone up. Well, so have they in the cafeterias of the hospitals where we feed patients, but our costs have not, and our reimbursement has not kept pace. So what we're having to live through, and it's going to take all of us coming together, because the solutions to this involves every one of you and everyone in your community, that I don't have a lot of answers for right now, but I do know one step at the time together and talking about this with those in Montgomery, with the governor's office. We're happy to help. We have to educate our communities of what's really at stake.
Thank you. Mark, a question for you. You're here today actually representing all the physicians in the state of Alabama. How are physicians looking at all this? What's the physician take on all this and some of the ideas you've heard to try and better the situation?
So, I mean, we're frustrated too. They're frustrated too. I mean, you made it early when you first introduced us, made a comment about the difficulty in recruiting. So we've got practices all over the state that are trying to bring in new physicians because they need, you've got physicians who have retired early from practice, who've, through COVID got burned out. We need physicians all over the state, and we have a hard time recruiting physicians to come into Alabama. That's why we try to home grow them. We're trying to use some of these programs that are in place now where if they're already here, we can keep them here as opposed to trying to bring some people in from out of state. So we've done a couple of things to try to make that happen, but we're just kind of dancing around the edges there. We're not making any real impact, and we're frustrated. They're frustrated. I mean, here in Montgomery, you think, oh, metropolitan area like Montgomery, it is extremely difficult to recruit physicians to come into this city. Reimbursements are an issue. I mean, let's just put it on the table. I mean, and I'm not throwing criticism anywhere, but our Medicare reimbursement is low. Our Medicaid reimbursement is low. And some of our payments through commercial insurance are low when you look at comparisons to other states. So these are conversations that we're having with people to try to make a difference, to try to change that, so that we can entice physicians to come into Alabama and live here and practice.
Thank you. Ted, from Blue Cross's standpoint, what do you think that insurance companies can do overall to help the crisis? And I know there's not that much, but what can insurance companies in Alabama do right now to help this crisis?
Well, one of the things that we try to do at Blue Cross, as I've mentioned on a couple things here, is partner as much as we can on various programs that you might think are a little bit outside of what a typical insurance company does, whether it's the partnership that Commissioner Boswell mentioned or the ACHNs that Commissioner Azar mentioned, working along with Dane for the last 5 years on a coverage gap solution. We are constantly interacting with our doctors, going to whether it's the Medical Association's board meetings or hearing from them. So we try to partner as much as we can, but the cost of health care is skyrocketing. That's just the way it is. It is particularly true, I'll mention, in the pharmaceutical area. The cost of drugs and therapies, there's an upside to that because we have miracle treatments that we never could have dreamed of 20 years ago, but the miracle treatments are awfully expensive. And so as we're trying to make sure that people do have access to that quality, affordable health care, and we hear from our physicians, our hospitals all the time about reimbursements, and we do understand that. We're trying to balance it as much as we can. The main thing we're trying to do, though, as I mentioned earlier, is we're trying to keep people healthy rather than trying to treat them once they get sick. That is a different focus that even I've only been with Blue Cross for 6 years, and even in the 6 years since I've been there, I've seen that focus shift significantly to where we are spending much more time making sure that our customers are doing what they can to stay healthy rather than just addressing it when whatever it is, the condition that they have has gotten to the point where they need treatment.
Thank you. One thing I also want to compliment Blue Cross on, and no, I don't own any piece of Blue Cross, is they engage physician providers in Alabama more than any other private insurance company does. They have physician advisory groups. They listen to feedback from physicians. They just don't enact policies and say, if you don't like this, just don't take care of our patients. So that's something good, refreshing, and I hope they really keep it up, because that partnership with providers and insurance, I can tell you, is going to have to be a cornerstone of whatever the solution's going to be. If these two groups aren't working together in concert, it's going to be infinitely more difficult to solve this problem. Commissioner, I agreed with you 200% on beds, 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 and I think she made a very good point that doesn't matter at all getting access to care and getting care for people with mental health issues if you've got no place to treat them. That's just totally obvious. So what can we do to help this bed problem other than hitting up our state legislators? What else, if anything, can we do to help improve this bed problem?
I think, again, getting involved with your local community and getting involved with your community mental health center and knowing what your resources are in your local community A lot of local communities are partnering. We have 3 different counties right now where we're using opioid settlement funds to partner with counties that also have local opioid settlement funds to stand up dually co-occurring civil commitment beds in communities. And so we would love to be having similar conversations with municipalities about how we might actually be able to take our resources and some of the resources you have in your communities to improve the bed capacity in your communities. We're doing that in Blount, Escambia, and Chambers County. So that is a conversation we would love to have. I'm going to give a number where you can get me, 242-3640. If you want to have a conversation about how to maybe partner and use some of your local opioid settlement funds to increase your bed capacity in your communities, I would love to have that conversation.
Thank you. And I want to emphasize that too. Just a show of hands, how many communities out here have either received or are hoping to receive opioid settlement funding? So it's quite a few. As we all know, this money can only be used for specific purposes. You can't buy police cars with it. You can't hire new public works employees with it. It has to be used for opioid-related things. And I think that mental health is a major thing that you can use this money for. And I would encourage you to reach out to, assuming you can talk to your other council members and mayors into it, reach out to your local mental health professionals and ask how you can partner some of these funds to get the most bang for your buck for improving mental health care in our communities. Commissioner? Hi.
I'm here.
I didn't mean to leave you out. Talk a little bit about for me, and I know you've talked about it a little bit, but what other preventive health things is Medicaid doing right now to encourage and promote preventive health in your population?
Yeah, we have hello? There we go. Yeah, like I stated, we have the Alabama Coordinated Health Networks, which is really to reach out upon those communities to coordinate care. And our ICN, all of those things are about promoting quality of care and incentives. And we also, this budget year coming up, we're looking to increase the baby well visit payment for that reimbursement rate, which is very much a preventative. Our nurse-family partnership is a huge in helping with maternal health and those sort of things. But one good thing we also did is we did apply for a grant, the Transforming Maternal Health Grant, which is actually supposed to be a 10-year grant, and we were one of the states that was awarded that at $17 million over a 10-year period, which is really going to look to transform how we pay for maternal health and our pregnancies, offering up things there that will be very good to help pregnant women a little bit earlier and do some things there that the state's not really done before. So we're very excited about that as well.
Sure.
Yeah.
I also believe there's legislation pending that would say that any pregnant woman in the state of Alabama gets the Medicaid first and then worries about the paperwork and the qualifications
Yeah, that's
second.
presumptive eligibility for
Right.
pregnant women. Yes, there is a bill in regards to that, and that allows a pregnant woman, if that were to pass, that could go into the doctor's office and could tell the provider what their income is, and they could allow them to be eligible for up to 60 days. And if they go in the system and they're determined ineligible, then they would come off. But if it would allow 60 days instead of waiting for it to be determined eligible.
And I think that's a very important thing because for maternal health, it's just obvious the sooner you get the care, the better for the mother and her baby.